Hello and Yali Mabet. Welcome everyone to the webinar on calling all women, young and mature, listen to your hearts as part of your Health is Your Wealth series. We invite everyone to sit back and relax while we have a candid conversation with our panel about how to identify and prevent cardiovascular disease in women. Before we continue, we would like to thank the volunteers who have helped us develop this webinar. I'd like to start with a land acknowledgement, where we acknowledge the traditional, ancestral, and unceded territory of the diverse Indigenous peoples all across Canada, and honor the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, the Musqueam, Squamish, and Tsleil-Waututh First Nations, Métis, and Inuit communities where we live and work. My name is Maheen Awadia, and I am a member of the National Non-Communicable Disease Prevention Team. I am currently finishing my Bachelor's of Science in Nursing degree at York University. I'm excited to be moderating today's presentation and look forward to learning from our three experts, Dr. Shaheen Jaffer, Dr. Salima Sharif, and also Marielle Dixon, who will be sharing her lived experience today. The objectives of today's session are to discuss heart disease in young women, share a lived experience of a woman with heart disease, explore heart disease in mature women, introduce healthy habits to de-stress. Before we get started, we would like the audience to know that any information provided in this webinar should not be considered medical advice and is not intended as a substitute for medical professional help, advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you have regarding your medical care. Without further ado, I will turn today's session over to Dr. Shaheen Jaffer, who is an internal medicine specialist in Vancouver, Canada, and has been in clinical practice for over 25 years. Her main areas of expertise are cardiovascular health, diabetes, and weight management. Over to you, Dr. Jaffer.
Bismillahirrahmanirrahim. Thank you so much, Maheen, for that kind introduction. Yes, so welcome everybody, and for the next 10 or 12 minutes or so, I'll be speaking about heart health in young women. And what I hope to do is review how common heart health in women is, the prevalence, also discuss all the different types of heart disease that women can experience, explain the risk factors, and also review how to prevent and manage heart disease. All right, I'd like to have the audience's participation as usual. So I'm going to repeat these 4 sentences, and maybe at home you can write on your phone or on a piece of paper whether each one of these sentences is true or false. So number 1, heart disease in women is a global problem. Pregnancy, number 2, pregnancy is a woman's first physical stress test. So just write down what you think, true or false. Number 3, having diabetes in pregnancy puts both the mother and baby at risk of developing diabetes in the future. And lastly, anxiety and depression are risk factors for heart disease. So I'll just give you a few seconds to finish off your thoughts. All right, well, let's dive right into it. What do we mean by heart disease? Heart disease is also known as cardiovascular disease. And it's really a general term for a variety of conditions that affect the heart and the blood vessels. And here on this diagram on the right, you can see that these blood vessels are everywhere in the body, the heart, the brain, arms, and the legs. And heart disease includes heart attack, stroke, blockages in the arteries, issues with the heart rhythm, heart disease with valves. Valves connect the upper and the lower chambers in the heart. and it also includes death from heart disease. Here on the bottom is a diagram of a slice of an artery, and you can see that early on, we could be, in our late to mid 20s, early 30s, a little bit of plaque, this yellow substance here, can develop. As time goes by, this plaque can grow and rupture, eventually spilling some not so nice material into the blood vessel. And this causes the body to react by developing a clot. This clot then obstructs the blood flow in this artery and results in the heart attack or the stroke. Now, did you know that women of all ages can be of higher risk for heart disease and stroke, more so than men? And in fact, heart disease is the #1 cause of premature or early death in women in Canada. Heart disease and stroke claimed the life of over 32,000 women in Canada in 2019. One woman's life every 16 minutes. So what that means that when this webinar is over, 4 women in Canada would have died from either a heart attack or a stroke. Women living with diabetes are 3 times more likely to die from heart disease when compared to men. And, I'm stating a lot of doom and gloom here, but in reality, there's actually a lot we can do to prevent or lower the risk of heart disease. Now, heart disease in women is a concern worldwide. It's a global concern. So here in this map of the world, you can see that even in North Africa, in the Middle East, and even in Central Asia, Afghanistan, Tajikistan, Kyrgyzstan, all of these places have high numbers of heart disease in women. So, anything in the orange, the light orange, dark orange, and the red. So anywhere between 7,500 and 8,500 women per 100,000 has heart disease in these countries. It's not as much of an issue in the high income countries, such as Canada and the United States, where it's a bit lower, about 6,500 in Canada and about 7,000. But that's still a lot when you consider how damaging heart disease can be to one's quality of life. Now, heart disease is on the rise, and it is the leading cause of death. It's not just that women get heart disease, but they actually die from heart disease. On the right-hand side is a diagram from the World Health Organization. You can see the lines. Canada is in red, the United States in green, Australia in gray, and the United Kingdom in purple. You can see that in Canada particularly and the United States, the rates of heart disease over the last decade have been increasing quite a bit. So that's not good news for women in the high-income countries. Now, heart attack symptoms are not recognized in over 50% of women. And what are the major symptoms most reported by women? Here on the right-hand side, as I've written, most often women will complain of a chest discomfort or a pain. Sometimes they have difficulty describing it. So they may, instead of pain, describe the discomfort as a tightness or a pressure or a burning. Or they may have, discomfort in the upper abdomen and may feel sick. They might have some nausea or indigestion. Those can be symptoms and signs of a heart attack in women. Or women may have discomfort in their jaw, in their neck, their shoulders, their arms, or even in their upper back between their shoulder blades. Or they may have really excessive sweating, or even fairly common is a feeling of shortness of breath on top of the chest discomfort. And women are more likely to have 3 or more of these various symptoms in addition to the chest discomfort. There may be other accompanying symptoms as well. A woman might feel very, very tired, very fatigued. They may feel like they're feeling lightheaded, or they may feel their heart rate really going fast. And as you can see on this video, this woman is obviously experiencing some discomfort. It may not necessarily be on the left-hand side. It could be in the middle, or it could be, in the jaw or the neck. So it's really important to understand and realize that symptoms could vary quite a bit. Now, women can be at greater risk for heart disease than men. Why is that? Well, we have some unique risk factors, such as pregnancy, for starters. Now, pregnancy is considered to be a woman's first physical stress test. In pregnancy, the mom can develop high blood pressure and diabetes. And diabetes in pregnancy doubles your risk of developing diabetes later in life, not just in the mom, but it puts their children, the offspring, at greater risk of developing diabetes in their lives. And guess what? Diabetes in pregnancy is more common in Central and South Asians than compared to Caucasians. And if you have high blood pressure in pregnancy, you are 2 times more likely of having a stroke or a heart attack or dying before the age of 70. So this is really important to realize that if you have high blood pressure or diabetes, it's very important for your future health as well. And I don't mean to scare our mothers-to-be, but stroke is 3 times higher in pregnant women than non-pregnant women of the same age. And unfortunately, many of us, not just the public, but even healthcare providers are simply not aware of these facts. So it's important to empower yourself with this knowledge that we're sharing with you today. Other risk factors that are specific to women include earlier menopause, under the age of 50, having polycystic ovarian disease, which is a lot of cysts in the ovaries, and often these women will also have high blood pressure, diabetes, and obesity, and also inflammatory and autoimmune conditions such as rheumatoid arthritis and lupus are risk factors for heart disease. Of course, cigarette smoking, we know, is a very, very significant risk factor, and diabetes by itself, so not necessarily just in pregnancy, but having diabetes gives women a 3 times higher likelihood of dying from heart disease when compared to men. And additionally, breast cancer treatments such as chemotherapy or what we call biologic agents, and even radiation treatment if you have left-sided breast cancer, are all risk factors for heart disease in women. Now, there are also well-recognized now heart disease risk factors that are psychological in nature and also socioeconomic. So anxiety and depression are mental health, and disadvantages such as being alone, having chronic stress. I describe women often as being the type E personality. So they're being everything to everybody every time. That stress, the stress of being unemployed, not having enough sufficient social supports, a lack of education, disability, where you live, your postal code, your fact that you may be, low income, poverty. These are all risk factors for cardiovascular disease. Domestic abuse and intimate partner violence, as well as our race and ethnicity. As I've said before, South Asian and Central Asian are high risk of having heart disease. Now, causes of heart disease can be different, as I mentioned, for women. So what's common? So both men and women develop what we call coronary artery disease. And what that means is that in that artery, and here you have a heart, and you've got all the blood vessels on the surface. These blood vessels, as I showed you earlier, develop plaque, and this plaque can rupture and block the artery. And that is the most common reason that both men and women have a heart attack, is what happens, as I've mentioned, plaque rupture. However, women can also have other reasons to have a heart attack. Some women, and our woman with lived experience, Marielle, will be describing her experience with what we call SCAD, or spontaneous coronary artery dissection, where the wall of the artery tears and you get a blood clot in the wall of the artery, and that blocks the whole artery itself. Or you can have spasm in the artery. Or you can have a small vessel disease where these thin blood vessels, they're really tiny, like they're the diameter of a hair. They go deep into the heart muscle. These can not function properly, and this happens more in women. That can give you, problems with your heart. and even a heart attack. And lastly, although this occurs in postmenopausal women, there's something called stress-induced cardiomyopathy. And cardiomyopathy is just a disease of the heart muscle. It's also referred to in layman's terms as broken heart syndrome. But this is mostly in older women, postmenopausal women. And it happens when there are sort of unexpected emotional or physical distress triggers. For example, if there is a disaster like an earthquake, or there's an unexpected death of a loved one, or, a very strong argument or a divorce, these are all examples of when women can get this stress-induced cardiomyopathy. Fortunately, this weakening of the heart muscle is treatable, just as all of the other conditions that I have mentioned to you. So it's important, again, to understand that women's hearts are different. And what you see on an angiogram, so many of you have heard what an angiogram is. So this, in the background here, this sort of globe is the heart muscle. And these lines here, these wiggly lines, are the main arteries that supply the top of the heart. And if you look carefully, you can see that these arteries go deep into the heart muscle. So these major arteries, these big arteries here, they supply 5% of the heart muscle circulation. What you don't see is, and this is where women's hearts are affected more than men, what you don't see are these tiny little microvascular blood vessels, these tiny hair-sized diameter blood vessels that they actually comprise 95% of the heart circulation. So again, this happens more in women where these tiny arteries don't work as well. Now, again, remind you that there's a lot we can do to help reduce the risk of heart disease. Heart disease is largely preventable. So these are the main factors we need to make sure we are doing. Make sure we're active, we keep moving. We eat a variety of nutritional foods, manage stress, whether you do yoga or however you decide, you go for a run or a brisk walk or you swim, it doesn't matter. Just move the best you can and keep your weight down. Avoid smoking, avoid alcohol. And what women don't do enough, I think, is get regular checkups. Because remember, we're at high risk. We have unique risk factors. So get tested with your blood sugar. Remember that pregnancy is a risk factor if you have diabetes and high blood pressure in pregnancy. Get your blood pressure and cholesterol checked regularly. And don't worry about needing to get medical treatment. There's nothing wrong with that. So to take care of others, as it says here, you first need to take care of yourself. So in summary, life, we don't want to miss it, right? And this is from the Heart and Stroke Foundation. Heart disease is a problem that's happening now. It's the #1 killer of women worldwide and affects women of all ages. Heart attack symptoms are not recognized in over 50% of women. We can be at greater risk for heart disease in certain conditions than men, and the causes of heart disease in women differ from men. Heart disease is by and large preventable, and there's a lot you can do to reduce your risk. And start the conversation, with your spouse, with your children. Start the conversation, because in both men and women, knowledge is power and prevention is the key. So let's finish off with those true and false questions. Heart disease in women is a global problem. I hope you said true. Pregnancy is a woman's first physical stress test. True. Having diabetes in pregnancy puts both mother and baby at risk of future development of diabetes. True. And anxiety and depression are risk factors for heart disease. True. Okay, well, that brings us to the end of my presentation. Thank you very much. It's been an honor and a privilege. So back to you now, Maheen.
Thank you so much, Shaheen. I will now be inviting Marielle Dixon to share her lived experience with us. Thank you so much for joining us today, Marielle, and taking time out of your busy schedule to share your experience. The questions that we would love for you to answer include, we would love to hear about your health journey, what changes you have made to support your health, and what would your advice be to other women in the community to support our heart health? Over to you, Marielle.
Thanks, Maheen, for having me and inviting me to speak today at the Heart Seminar. I'd be happy to share a little bit about my health journey. My cardiac experience or episode began in May of 2012. I was about 5.5 months postpartum. I had a newborn pretty much and a 3-year-old at home at the time. And I had, leading up to my episode, I had what now I know was angina, but I didn't recognize it at that time. I had been out trying to exercise and get fit again. I'd been going to Zumba classes, and I noticed after the end of my Zumba classes that they're pretty intense, but I managed them. I got out of the class and walked to my car, and my elbow started to ache like I had pulled a muscle or something. And there was a lot of Bangra moves. So I thought this was actually what I had done, was pull the muscle. So I'd rub my elbow. It sometimes would go a little bit up to my armpit. And by the time I got home and sat on the couch for a few minutes, the feeling would just go away. So I really didn't think too much of it. And again, I just gotten back to exercising. So kind of pushing it felt normal. That happened a couple times. And then I had one episode where I had just been walking with friends, and I had the same sensation. And I was not walking strenuously, like it was a stroll. And so it was really odd that my elbow felt like I'd pulled a muscle again. And I was like, oh, that's odd. So again, just kind of went home, relaxed, didn't think too much of it because it resolved so quickly, like within about 15 minutes. That was a Saturday night. By Monday morning, I was home with my kids. I had kind of woken up, and I felt rough right from the time I got out of bed in the morning. I just felt really fatigued and irritable, and I had kind of a stressful morning with my toddler, and I couldn't get my baby down. I finally got her down for a nap, and I was like, I need to have a shower. I need a few minutes for myself. And I got in the shower, and I was in there, and I just had this feeling like I need to get out of the shower. I need to get some clothes on because I need to go to the doctor. And I couldn't explain it any more than that. I don't even remember really if I had any arm pain or anything at that time. I just felt really unwell. And so I called my mom. I asked her to come over and watch the kids. And she asked me to call 811 in the meantime, and she was going to come help. So I went down, sat on the couch, called 811, and I kind of relayed all what was going on and how I was feeling to them. And the nurse said, you need to call 911. So I did. I called 911, and I live really close to the fire hall. So as I'm on the phone with 911 and telling them what's going on and feeling like I'm being way too dramatic about all this, I can hear the sirens start and the firemen are on their way. So within a few minutes, like probably less than 5 minutes, I had 6 firemen in my house. I was on oxygen. I was sitting on the couch, and the paramedics were on their way. Paramedic came in and checked me over, and basically said, yeah, I think you're having angina. My blood pressure was really high. I think it was like 190 on 100. And by that time I was a little bit short of breath. The arm pain was back. It was up to my armpit, and I had like a little bit of back pain, I would say, like kind of between my shoulder blades. So anyways, all said and done, I was packed up, put in an ambulance, lights and sirens all the way to the hospital. And I work in healthcare. So this is a place I'm used to being, but I'm not usually in the stretcher. So this is really weird for me, being in the patient side of things. So got to emerge. They did the usual ECG, blood work, put me into a monitored bed. Nothing really was showing up. And I was like, it took hours. And I was getting sort of anxious about, I need to get home. I got to go feed my baby. I have stuff to do. I had a baby shower the next day I was planning. Like I had my list going. My cell was on. I was still managing from the bedside. So eventually I'd been there for so long and everything looked fine and I was very stable. So they moved me out of the intensive care area in Emerge, I guess, or the acute area in Emerge, put me back to treatment, which is basically chairs. And so I was sitting in chairs for another 3 hours. And it's a policy in most hospitals. If you've had certain cardiac symptoms, they generally do 4-hour blood work and then they let you go home if everything looks good. So I was waiting for 4-hour blood work. And I remember sitting in my chair with my husband and, telling him about all the things I needed to do. And I was watching the nurse at the desk, and she got blood work on the fax. We still get faxes, believe it or not, in the hospital. And she picked up blood work and then looked over at me, and then looked back at the paper, and then looked back at me. And her face just changed. And she walked right over to me and she said, "I'm sorry, you're going to have to get back in that chair. I got to put you on a monitor. Your troponin is elevated. And until we know more, you've had a heart attack." And that was kind of like, wow, that was sort of how the world changed for me that day. So I was admitted. I think I was in for about 5 days. I thankfully met Dr. Sharif, who's been fabulous. And I ended up going for cardiac cath the next day at another hospital. And they found that I had an 80 or plus % occlusion of one vessel down the main part of my heart. And I didn't have any notable heart disease or obstruction in any other vessels. He said, "Your heart is pristine everywhere except for this one spot. It looks weird. I can't explain it, but you need a stent." So that's what happened. I ended up getting a single stent in my heart and was brought back to the hospital for recovery and kind of all the fallout that happens when you've been told you have heart disease. So you asked me as well too about, sort of, did I anticipate my diagnosis and how I felt about it and what was my biggest lesson? Those were some of the next questions you asked. So for me, of course, I did not anticipate my diagnosis. This was not on the radar at all for me. We do not have a family history of young heart attacks, a bit of hypertension, but that's about it. I didn't feel like I had a lot of the risk factors. I didn't smoke, didn't really drink. I didn't have abnormal stress, I didn't think. So lots of things. I was a bit overweight. I guess that was really the only thing that I thought ticked a box for me. And the fact that my heart looked good everywhere else except for this one vessel just didn't make sense. So for me, I had a real struggle accepting the diagnosis of heart disease as in a sick, full of plaque heart, which is kind of how we have to treat people like me when you don't really know what happened. So anyways, that was a long process for me. And I went through it with Dr. Sharif, and she was very understanding and listened. And I think she also knew I needed a proper answer. I needed to understand what happened to me. So I didn't really accept the diagnosis of just coronary artery disease in one vessel. And I kept looking, and I kept finding this thing on the internet about heart attacks in women, in young women, are often related to something called a SCAD. And I ended up getting sent to a specialist who reviewed my case, redid my cath lab about 2 years later, and actually found that I had a 3-centimeter tear in my artery, which had likely caused my body to try and fix things, which then caused a clot. And that's what caused my heart attack. So I had been diagnosed with a SCAD after the fact. And so that diagnosis, oh, good, now I know why, or I know what happened, and it made more sense to me. But it actually didn't make it much easier to get along with my life, just because SCAD's not a great diagnosis, to be honest with you. It's very unpredictable, I guess. And everything I learned, it also repeats itself, or it can in a lot of patients. And so that's a bit scary. And a lot of the factors that cause SCAD, I didn't really feel like I had very good control of, or the ability to maybe regulate those things in my life. So I did have hypertension that was related to my pregnancies, and I had hypertension after I'd had the babies too. I also was going through a lot of hormonal changes, which you can't do much about when you're in childbearing years. I was breastfeeding, I was still losing my hair, all that kind of stuff. I was definitely dealing with postpartum anxiety. So I had a lot of uncontrolled stress. So those are definitely risk factors for SCAD. So now I realize I did fall into those categories. And I think Dr. Jaffer mentioned, the type E personality where you're trying to do everything. And I think that was me for sure. So yeah, I guess that's one of the things I learned, is that despite having a diagnosis, it doesn't actually always make it easier. And it kind of like put me in a position where I then had to deal with the new diagnosis and started dealing with how am I going to manage all those stressors and things. So I felt kind of like pretty useless and angry for a while, a lot of denial. I'm just going to do whatever I shouldn't do because that's my personality. But, they said I shouldn't lift stuff. I shouldn't go on roller coasters. You have to take a lot of pills. You have to take all the pills heart disease, coronary artery disease patients take still to prevent future events. So I guess, yeah, lots of anger, denial, grief, the whole thing, losing your good health or what your thought of good health is. So that took a while, and I needed to get a lot of help for that. So that's the thing that I think changed most for me, or that I've had to learn to accept help to help deal with some of the stressors and things in my life. So at the time, of course, I got lots of help with the kids. I asked for physical help around the house. When people offered, I accepted. I took medication for my hypertension. I took medications for my anxiety. And, I just now know I'm always going to need to have routine testing and blood work and MRIs and ultrasounds. And that's just part and parcel of being a cardiac patient and looking forward to staying healthy. And that's just part of it. So that's how I support my health now. I did things like joining a SCAD support group that they have at VGH through this other doctor that I went to see, and that helped meeting other women that had gone through the same type of problem. And they're a lot younger than the previous heart rehab I'd gone through. This population was kind of in my age group. And I realized I was so lucky, because some of the women there were so debilitated by what had happened to their heart. And one woman was only probably 5 years older than me, and she had 4 kids, and she was on a transplant list waiting for a new heart. Her heart had been so damaged. She had had multiple SCAD attacks. So it gave me a ton of perspective by just reaching out and getting help and support from other people who had been through things like this. I felt super lucky. So that was helpful. I did also have a time where I had the odd panic attack, which really, as a healthcare worker, I'm pretty used to dealing with stressful situations, and I'd never experienced anything like that in my life. So it was really unsettling to just have, like, out of the blue, like a full panic attack while I was driving, or, just felt really out of control sometimes. So I did go to a counselor for a while, and that helped. And, just talking about trying to find my balance between a diagnosis and how I wanted to live my life, and kind of taking control of things in a way that felt comfortable while still recognizing that I needed to do things differently. So that was great. It's been a real journey. It's been like 12 years. So, like, the longer it's farther away, it's not at first of mind all the time now when something happens. Of course, when I feel ill or sick, my brain does go there, of course, but I don't worry about it on a daily basis. And I do stuff. I do fun stuff all the time. I do go on the odd roller coaster. I lift the odd heavy thing, or, piggyback my kids occasionally, things when I feel like I can. Like, I do hard sports when I want to. I love to windsurf. I ski. I have to find a balance mentally and physically. And because I was really lucky, I don't have a lot of heart damage. So I'm trying to stay active. And so that's some of the things. What else? I have to check my notes here. I have a lot. Just kind of remembering to take, and we always hear about this as women, take time for yourself, to do things for yourself. But I mean, I can't emphasize that enough, because if I had not slowed down, who knows if I'd be here to take care of my kids. And so you just really have to find room in your life for your friends and for things that make you happy, because you have to refill yourself. You have to take care of yourself, because you will not be around necessarily to take care of someone else. So I guess I just wanted to say thanks for letting me tell my story. I hope that sharing my experience helps someone else. It can be you. I guess that's what I wanted to say, especially to younger women out there, is that recognize that our stressors and our risk factors are not the same of what we've been led to believe. It's not all about diet and smoking and drinking and all those kind of things that we always associate with heart disease, which are definitely risk factors. There are other stress factors of being just female and being moms and being, going through all the changes in life that really put us at risk for other things. And we just need to be aware that that can be an issue. Sorry about that. And so, yeah, that's just what I wanted to say. So thanks for having me. Please take care and stay healthy.
Thank you so much for sharing your experience with us, Marielle. We really, really appreciate it. I will now be handing our presentation over to Dr. Salima Sharif. Dr. Sharif has worked as cardiologist at Surrey Memorial Hospital, where she works in critical cardiac care, consult service, echocardiography, and pacemaker diagnostics. Dr. Sharif has a strong interest in women's cardiovascular health, preventative cardiology, and a special interest in the South Asian population. Over to you, Dr. Sharif.
Thanks so much, Maheen, for that introduction. And what an honor it is to be asked to speak at this amazing webinar for women's health. And it's my absolute pleasure to present today. So the title of my topic is Hot is the New Black. And we're going to be talking about hormone replacement therapy in postmenopausal women and their cardiovascular risk. So when we see a slide like this, or we see a picture like this, because of the power of social media, the power of information, we all automatically know that that diagnosis is menopause. It doesn't take too much sort of, thinking to sort of know that we're talking about menopause when we see hot flashes. So what we're going to do is we're going to be talking a little bit about menopause. We're going to be talking about some case slides, some definitions and current guidelines, and some suggestions to thrive as your estrogen dives. I'm sorry. So I'd like the audience's help at this time to see if they can help answer these two questions that I have about two patients. These are real patients. They came to me in my practice and they're asking for help. So let's see how well the audience can sort of help me in their minds if this is your sister or your mother or a friend asking the same questions. So my first patient, she's 55 years old. She has a history of well-treated hypertension, and her last menstrual period was at the age of 51, so less than 10 years ago. She's got quite severe postmenopausal symptoms. So she's having a lot of hot flashes. She has no history of breast cancer, no history of heart disease, liver disease, blood clots, or stroke. And she says to me, "Doctor, can I take hormone replacement therapy, or what we call menopause hormone therapy, or MHT? And will this protect my heart? Will it help my symptoms?" So just think about that. Is that something that you can relate to? Is that something that you can answer for this patient? And hopefully by the end of this webinar and after the end of this talk, we'll be able to answer this for this patient. My second patient, she's 65 years old, and she had her last menstrual period at the age of 52. So that was more than 10 years ago. She has had a previous heart attack when she was 62, and she had a stent placed in her main artery. She's now come in with lots of symptoms of fatigue. She's had some vaginal dryness. She has a history of osteoporosis. She does not have any history of breast cancer, blood clots, or stroke. And she asked me the same question: "Doctor, can I take hormone replacement therapy for helping with some of my symptoms, but also to help prevent another heart attack?" So hopefully by the end of this webinar, we'll be able to have some information and give both of these patients some good advice based on the guidelines and the evidence. So what we're talking about today is estrogen. Estrogen is a really powerful hormone. And when we think about hormones, they're basically just molecules in our body that have effects all over our body. When we think of estrogen, we know that estrogen is a very protective hormone, and it actually protects women when they are in their premenopausal state from having heart disease. The way that estrogen helps women have less heart disease than men in the premenopausal state is that it actually has a really good effect on lipid profiles. It helps lower the cholesterol. It has something called enhanced endothelial function. That's just a fancy word for what we describe as heart specialists, the lining of your heart arteries. The lining of your heart has something called endothelium. And when the endothelium is inflamed, that can lead to blood clots and plaque going into the arteries and creating heart disease. So when we have a smooth endothelium and it's nice and clear, that helps protect our heart. And estrogen is thought to enhance that smoothness. And we'll talk a little bit more about that too. The important thing about this next picture that I'd like you to see is when we look at estrogen hormone levels, we basically start when we're as children, and as we go towards our 20s and 30s, the level of estrogen starts to actually gradually increase. And you can see from the figure here that the lady has the coloring in red is her level of estrogen. And we reach our peak estrogen level actually by the time we're 35. And that's why they say women are at their peak at 35. And then you can see in terms of the estrogen level, it starts to decrease from the time you're in your 40s to your 60s. So if you look at the estrogen, if you look at the lady, the red coloring, she starts to reduce her estrogen level. We as people, as women, start to reduce our estrogen levels from the time we're 40. By the time we get to 50, you can see that half of our estrogen level has dropped quite dramatically. And then by the time we get to the age of 60, you can see that the amount of estrogen in our bodies has diminished down to, you can see at the level of the thigh. This is just a graphic representation. And by the time we're in our 70s and 80s, the amount of estrogen is very minimal. So you can see that dramatic amount of drop in estrogen level from the time you're 40 to 60. And that's actually where we start to define menopause. So this is a really important take-home point, that you can see the dramatic changes that happen in a woman's body in regards to the hormone level, especially for estrogen. And when we talk about menopause, I think when we're younger, we think of menopause and we think of quite elderly people. We think of, women that are much older than we are, or I am. But actually, this is the age that we're looking at. This is a tribute to Aishwarya Rai. She is actually in that stage of menopause, because women have the average age of menopause in women is 51 years old, and 95% of women become menopausal between the age of 45 and 55. And estrogen is one of the most effective treatments to relieve menopausal symptoms. This is an important point in this slide here. So if you look at the female life expectancy, from the time of the 1850s to current, our life expectancy has increased from, say, 45 all the way up to 86. So our life expectancy for women in Canada today is around 86 years old. The age of menopause has actually stayed consistently the same, regardless of what changes have happened in health. The age of menopause is still around 51 or 52. So that means that women currently will spend more than a quarter of their lives in menopause. And this is very important, because so many changes happen in our bodies, so many changes happen in our heart, that we have to be prepared for these changes, because we're going to spend a quarter of our life in this state. So we remember, Linda Carter, she was the prototypical Wonder Woman, and she had estrogen when she was in her 30s. And here she is now in her 60s. She's definitely, actually, I think she's 70, but she's definitely postmenopausal. And the estrogen level compared to premenopause to postmenopause at this level has started to decline quite rapidly. And when we talk about estrogen loss, it's not just our natural menopause where your ovaries start to produce less estrogen, but you can actually have early estrogen loss, like a surgical menopause. If you've had surgery on your ovaries or had a hysterectomy, that would be a premature early surgical menopause. Certain chemotherapeutic agents can also induce menopause. And people can also have, women can have premature ovarian insufficiency, which can lead to premature menopause, which in those people then mean that they will spend more than a quarter of their lives, maybe even half their lives, in a state of menopause. So when you say menopause, we think of many things. We think of things like nausea, maybe memory loss, hot flashes, your body temperature changes. Those are common things that we think about with menopause. We're also quite well versed with osteoporosis in menopause. When we talk about menopause, physicians often think about the osteoporotic effects, and you can see, our spine changes because our bone density reduces in menopause. But I would like you to think also the other things that can happen during menopause. And the most important thing is that with menopause, the the degree of heart disease starts to increase. And heart disease is actually the number one killer of women in North America. And that also is related to menopause. Once we reach a post-menopausal state, our risk of heart disease starts to become equivalent to that of men, and our estrogen no longer protects us from not having heart disease. So that's a very important thing to remember. So what do we do about estrogen and the heart? These next few slides are from Dr. Moss, who presented at the Barcelona Congress, European Congress in 2022. And it's a busy slide, but I just want you to look at the middle of the slide. When we talk about menopause, many things happen. So for example, we start to gain fatty tissue in our central abdominal region. We start to be more prone to getting diabetes. We start to have changes in our lipid profile, whereby we start to get higher bad cholesterol, which tends to stick to arteries. So these are all what we call female-specific risk factors for heart disease because they're associated with menopause. So remember, we talked a little bit about that endothelium, the lining of the heart. So this slide is basically just to remind people what that looks like. So when the lining of the heart starts to become inflamed, it tends to get all sorts of red blood cells and white blood cells and inflammation that leads to plaque buildup. And that plaque buildup is what causes blockages in our heart arteries, and that can lead to a stroke. And if it's not in our heart arteries, it can happen in our brain, which can cause, it can be in your heart arteries, which can lead to a heart attack, but it can also be in the arteries to the brain, which can cause a stroke. And if it happens in your lower legs, it can cause peripheral vascular disease. And if that plaque buildup happens in your kidneys, that can cause kidney disease. So that endothelium, keeping it healthy is very, very important. And when we talk about the benefits of hormone replacement therapy, this is really a benefit of a timing benefit. Getting the right timing and replacing hormones when we start to go into menopause is a very important thing. So on the early slide where you can see that there's no plaque buildup on the one artery, when we give hormones in this setting, when there's no plaque buildup, we actually have a lot of benefits. We actually produce good endothelium. We allow less plaque buildup, less heart attacks. But once we have already established plaques, once you've already got plaque in your heart, giving hormones actually at this level is quite dangerous. And it can actually lead to more plaque instability and can actually lead to more heart attacks. So when we talk about replacing hormones in women, we want to make sure that we have the right risk profile when we have good information about what your arteries already look like or what your risk already is. So remember, replacing hormones is a timing issue. And again, if we look at heart disease, this is just a CT scan of a person that has major calcification in their arteries in their heart. That means their endothelium has already become inflamed, the plaque has already started to build, and that causes heart disease. And this lady is having a stroke. You can see the asymmetry in her face, and in her, the plaque has already formed in the arteries to the brain, and that can cause a stroke. So again, that endothelium is very important. So patients ask, so if estrogen protects women from heart disease, why don't we replace it as soon as it starts to fall? And again, we know that giving hormones when you have nice, healthy arteries, that's important, versus giving hormones when you already have plaque, that's dangerous. So what do the current guidelines say? Now, guidelines are just guidelines. When it comes down to an individual patient, this comes down to a discussion between you and your doctor. The benefit of hormone replacement therapy is really based on your age, since you became menopausal, and your risk of heart disease. Because when we give hormones in a postmenopausal state, there can be harm associated with that. There can be harm with estrogen alone or estrogen and progesterone. So it becomes a very careful discussion. And the takeaway point here is that every person person is individual, their risk is individual. Your risk of having heart disease and replacing hormone replacement and having hormone replacement therapy will really come down to a very careful discussion with you and your care provider. Just to reiterate some of the guidelines, these next few slides, again, from Professor Haas, which I'd like to thank for the talk that she had presented at the European Congress in August of last year. And when we talk about hormone replacement therapy, we know very well, we recommend it for women that are under the age of 60, where their onset of menopause has been less than 10 years, and their risk of breast cancer and heart disease is still low. On the other end of the spectrum, if you have a high risk of breast cancer, which they define as anyone is having breast cancer or has a first-degree relative that has breast cancer, or if you have established heart disease, then you would not be a candidate for considering hormone replacement therapy. And then there's a gray area, which comes down to a moderate risk where we could consider with caution. And in terms of what we use, that's a whole talk all on its own, but we talk about women using just topical estrogen all the way down to using estrogen and progesterone as tablets. And the combination of treatment really depends on your own individual risk. And that would be a discussion again with your healthcare provider. So again, the most recent update really hasn't changed in the last 5 years, but we're becoming more aware of the fact that you might want to consider hormone replacement therapy in that perimenopausal age, because it can reduce some of the risks of heart disease. It can reduce some of the symptoms. We know that those hot flashes actually are directly related in terms of risk profile for developing heart disease in the future. So it's not just about, we hear all the jokes about, oh, I'm having a hot flash. That actually is a vasomotor symptom, and that vasomotor symptom can in the future put you at risk for heart disease. But we also know that hormone replacement therapy can cause risks such as blood clots and strokes. So we need to, again, balance the risk of hormone replacement therapy with benefits of hormone replacement therapy. And just to sort of guide women, because there was an article published in Forbes in 2019, and basically the title of that article, and that really hit home for me and for a lot of my patients, was that doctors are actually failing in their approach to women when it comes to menopausal care. And it's because we're not included as much in research studies, and it's because, often studies aren't done in women of this cohort and this age. But when I went to medical school, and the teaching that we were given was really very fear-based, based on some of the studies that had come out early in the 1970s, and we're still relying on some of that old literature. And a lot of the conversation between physicians and patients is driven by that fear. But I want you to know that it's still not considered poison necessarily, but that's how some healthcare providers think of hormone replacement therapy. So it does come down to discussing your risk benefit with your provider, and I would highly recommend it. So going back to my patients then, now that we've got a little bit of background, a little bit of information. So my 55-year-old female, she has a history of well-treated hypertension. Her last menstrual period was less than 10 years ago. She was age 51. She has very severe postmenopausal symptoms, and she really doesn't have any risk factors such as breast cancer, previous heart disease, liver disease, blood clots, or strokes. So in her situation, when she says, "Doctor, can I have hormone replacement therapy or menopause hormone therapy? And will this protect my heart?" The answer for this would be yes, you probably could have hormone replacement therapy. We know it'll treat your postmenopausal symptoms, and it will probably protect your heart based on our current literature. And then our next patient, the 65-year-old female who had her last menstrual period more than 10 years ago. She has established heart disease. She already has a stent in her heart. She's got some mild symptoms of menopause. And although she doesn't have any risk factors for taking hormone replacement therapy, because she has established plaque in her arteries, hormone replacement therapy in this patient would be quite dangerous. So we would say no. But there are other things that women of this category can use. There's all sorts of medications that we can use for vasomotor symptoms. There's all sorts of vitamin supplementation and health guidelines, which again are very important to consider if you're not a candidate for hormone replacement therapy. So it's not all doom and gloom. It does come down to speaking to your healthcare provider, staying healthy. And I just have a few take-home points that we can use for women that are going through menopause and as their estrogen dives, what they can do to try to keep healthy. So in regards to high cholesterol, I would recommend that you would get your cholesterol tested every 6 months through your healthcare provider. CRP is a measure of inflammation, and we use it as an indirect way of looking at the health of your endothelium or the lining of your heart. So when your CRP is up, and it can go up for a number of reasons, but if you're otherwise healthy and your CRP is climbing, that can be a risk factor for inflammation and heart disease. So I would recommend that that be put on your yearly checkup with your healthcare provider. And eating a rainbow diet full of fruits and vegetables is really important in terms of reducing cholesterol. And when we talk about metabolic syndrome, again, measuring belly fat, that can be a risk factor for heart disease. I would recommend that your fasting sugar, your A1C, be checked regularly, your blood pressure be checked regularly, and to watch your salt intake and lots of regular walking. We know that depression and stress can be significantly associated with plaque rupture and leading to heart attacks and strokes. So again, a discussion with your healthcare provider about your mental health, having lots of social interaction, meaningful connections with your family, friends, meditation, yoga, they've all been shown to reduce stress and that in turn reduces inflammation in your heart. And if you have disrupted sleep, which is commonly associated with menopause, you get this menopause sort of fog because of a lack of sleep. Again, things like checking for sleep apnea to make sure your condition isn't being worsened by this, and checking your blood pressure, which can often go up when you have untreated poor sleep. So again, regular visits with your family physician, discuss your individual risk benefit and the treatments associated. And so that's my talk about hormone replacement therapy and menopause. And again, I thank you very much today for listening to us. And thank you again for inviting me to speak today.
Thank you so much, Salima, for your presentation. So as we heard from our experts today about how stress can contribute to heart disease, let us talk about the last pillar of 5 to Thrive, de-stressing. Stress is a normal part of life, and not all stress is bad. Although when stress is allowed to build without recovery, it can lead to health issues such as high blood pressure, chest pain, frequent infections, and anxiety. Practices that help us focus on the present moment, like mindfulness, can help reduce stress. We need to balance stress with recovery and rest to build our body, to keep our body and mind healthy and help us make better decisions. So, as seen in this infographic here, mindfulness practices like breath work, self-checks, and yoga can balance stress and improve our physical, emotional, and mental health. These practices help calm us down and make us aware of our thoughts, feelings, and emotions. Thus, practicing easy strategies to manage stress and following a healthy lifestyle has been associated with lower risk of heart disease, stroke, diabetes, high blood pressure, and also illnesses like dementia and depression. So following healthy habits can add more than a decade to life expectancy. Just like brushing your teeth needs to be done every day, all the 5 to Thrive pillars require daily practice to keep you healthy and well. So visit iicanada.org/5 to Thrive to check out all of the infographics and resources that we have available to find quick, easy steps you can take to set you on the path to better health. So now I'd like to bring our panelists and guest speaker back together and ask you to each provide us with any additional thoughts for women from today's session. Shaheen, I'll start with you.
Great. Thanks for the opportunity, Maheen. So what I'd like to touch upon really is what we nowadays, consider best practice in our lives. And as you recall, we've had lots of guidance recently about achieving best practice. So it's essential, as far as I can see, to have the active participation of women with lived experience. WWLE, we call it, Women with Lived Experience. And really trying to encourage women to share their experiences about their health and their challenges and their successes as well. And that holds true for men as well. We'd like, our community, our members of our Jamaat to start participating in these webinars. So please reach out to your health board and volunteer to share your stories. And that's really for the benefit of us all. Thank you.
Hi again. I just wanted to have or share a couple final thoughts. So I think my advice would be is to, for women is to continue to attend things like this lecture and stay interested and stay engaged in your own healthcare. Be your own advocate. If something doesn't feel right or doesn't fit right, keep asking questions to get the answers you need to help you move forward. If you do have a diagnosis like mine, be aware that heart disease can happen in otherwise healthy appearing women, young or old, and that our risk factors are not the same for men. So we really need to be aware of that because it doesn't always happen in people you would expect. So yeah, keep talking about it and take care of each other and take care of the women in your life. Thanks so much.
So in regards to my final thoughts, well, first of all, I would just like to take this opportunity to thank my patient, Marielle, for volunteering to share her story. And I get emotional every time I listen to it. So thank you so much, Marielle. I think your story is going to help women that listen to this, patients that listen to this of all ages. So from the bottom of my heart, I just want to thank you. And thank you to the team for inviting me to speak today. I really enjoyed participating, and I actually learned lots as well from all of you. And just for women out there, I just want to remind you that, knowledge is power, and attending these webinars are really, really important. I think that, it helps you to understand what you face and the things that your body is going through, and that what you're feeling is very normal, and the changes that your body goes through is quite normal. It's so important to speak to your healthcare provider when you're experiencing symptoms that you're not comfortable with, because I think that will help you stay healthy in the future. So again, thank you again for inviting me, and stay healthy, be well.
All right. Well, this brings us to the conclusion of our webinar today. I would really like to thank our experts, Dr. Shaheen Jaffer, Dr. Salima Sharif, and Marielle Dixon for sharing their knowledge, experience, and expertise with us. I would also like to thank all the volunteers who made this webinar possible. Lastly, thank you to our audience. I hope you really enjoyed the last hour and learned things about identifying and preventing cardiovascular disease in women. Steps that you can take towards looking after your heart health. For everyone who has registered and provided their consent in the registration form, we will follow up with you for an evaluation. We are extremely grateful for all of your feedback, as this guides us to develop future programming. Before we close, I'd like to mention our next webinar will be held in April, where we will explore cancer screening and prevention. Till next time, and ya Ali Madad.